Respiratory events after tonsillectomy. Hi, my name is Romain Johnson. I'm an associate professor of pediatric otolaryngology at UT Southwestern Medical Center. And so I'm interested in complications after tonsillectomy. In particular, I'm interested in respiratory complications as an airway doctor. And respiratory complications include unplanned intubations, oxygen requirements, acute PAP therapy, or respiratory arrest even. And nationally, there's about a 2.5% incidence. We found that looking at a cross-sectional analysis of the inpatient database. And the increased risk of respiratory complications are among kids with severe sleep apnea, Down syndrome, as well as perhaps Black children. So when we looked at Black children in particular, we created an unadjusted and adjusted model of respiratory complications, interventions, and events. Events included both complication and intervention as a binary variable. And what we found is that Blacks were about 1.5 times more likely to have a respiratory event in the adjusted model. The question is, why do Black children have an apparent increase in risk? Is it because they're younger? Age is definitely a risk factor for respiratory events. Is it because of obesity or OSA severity? Is it asthma related? Are there structural biases, which would be pretty important to know? And so I think further research is needed. So we decided to look at a group of children with severe OSA for respiratory complications after tonsillectomy. And we hypothesized that the difference in more comorbidities and disease severity, for example, sleep apnea, contributed to Black children having higher risk of respiratory issues. We included all children less than 18. We included children with severe sleep apnea by polysomnography and HI greater than 10, and they had to undergo a tonsillectomy. We analyzed respiratory complications by race, ethnicity as our primary analysis. We used analysis of variance for continuous variables and the Pearson chi-square test and logistic regression for categorical variables. And we did some cross-level interactions looking at race and asthma. So the study included all patients in 2019 with severe sleep apnea. There were 449 patients. The age, we excluded patients with tracheostomy, patients with cerebral palsy. We did include children with Down syndrome and other comorbidities. But the two main ones, trachs and severe cerebral palsy, we excluded. The average age was about 5.6 years, mostly male, good distribution of patients. This is North Texas, so we have a lot more Hispanic patients, but overall had a good number of Black, white, and other children. We found that 48 children had a respiratory event, about 11%. 19 of 118 Black children had an event, and 29 of 302 not Black children had an event. So that showed that Black children in this population had an increased percentage as well as the odds of respiratory events, 16% versus 8.8%. And then logistic regression showed an odds ratio of 1.998. So the question is, what about confounders? Maybe it's not just that Black, there's other things involved. So we did look at some confounders, and what we found is that, there were some that were different between the two groups. For example, age, Black children were younger, not unexpected. That's been shown before that Black children are younger on average who undergo tonsillectomy. The BMI Z-score was lower compared to other children. I think that has something to do with Hispanic patients. The Hispanic patients tend to be a little bit more obese, especially those with severe OSA. Pulmonary disease, not asthma, but other pulmonary disease like bronchopulmonary dysplasia, chronic lung problems, more common in Black children. And then sickle cell disease, obviously tip the age in terms of hematology patients. When we look at the sleep study, the preoperative sleep study, the HI was similar, which is good. That means all the patients were severe, didn't show Black children were at a higher severity rate for AHI. Some of the other variables, though, did show differences. For example, the percent time below 90%, the average in tidal CO2 as well as the peak end-tidal CO2, as well as percent time of end-tidal CO2 greater than 50. All those showed favored Black children. Tonsil hypertrophy was less so in Black kids, and adenoids was a little bit more, and more those kids wound up in the ICU, more Black children wound up in the ICU, and the length of stay was longer. And that's pretty consistent with previous data that I've seen, that Black children tend to have longer lengths of stay. So when we look at the overview of the confounders, Black children were younger, have bronchopulmonary dysplasia and pulmonary disease, sickle cell anemia, the CO2 differences on a sleep study, adenoid size, and possibly asthma. Asthma was not statistically different, but the p-value was fairly low. I think it was about 0.15 or so. So that means asthma may be playing a role. We need to look at it further. Black children were less than other children with respect to obesity, tonsil hypertrophy, and central apnea. So what predicts respiratory complications, which is our key variable, our key outcome? And we know that Black children in a univariate analysis showed increased risk. But when we add other variables and we do a multivariable analysis, we find that percent time SpO2 is less than 90% was the key predictor of respiratory events. It overruled all other variables associated with this problem. When we looked at then what is the relationship between desaturations, which was the percent SpO2 below 90%, I called it desaturations, in Black children, we found that there was no difference between Black children and other children. However, the p-value again is fairly low, it's 0.12. And again, if you're doing an exploratory analysis, a p-value that low is worth pursuing a little bit more to see if there's some relationships there that, that need to be hashed out. So I tried to build a statistical model of respiratory desaturations. And what I found was, pardon me, when I say desaturations, I mean the SpO2 90 less than 90%, or less than percent time less than 90%. And so when I do this type of modeling of DSAT, I did find that Black asthma and having an event formed a three-way interaction, what we call 3x3 model. And this is a graphic representation of the model. And so if you look at Black versus not Black, asthma versus no asthma, and no complications, you find that the line is pretty flat. The percent time below 90 is relatively stable. But when we add respiratory complications to the mix, if you had asthma and you weren't Black, you spent more time below 90%. But if you were Black and had asthma, the level dropped. You spent less time than with your SpO2 below 90%, which is interesting. So we need to look at this more, but this is what the data suggests. So univariate analysis, Black children with severe OSA have more respiratory complications after tonsillectomy. The polysomnographic variable, percent time SpO2 less than 90%, predicted the respiratory events. The more time you spent below 90%, the greater likelihood you're going to have a respiratory event. But Black children's SpO2 scores were similar to other children. But when we build that model to try to model respiratory events and desaturations, Black children, asthma, and respiratory events formed a 3x3 statistical model. So what does that mean? What does it possibly mean? All right, here's my hypothesis. So it is sleep apnea's effect on pulmonary function rather than degree of obstruction that predicts respiratory events. Black children have more reactive airway problems, and that is the reason for their increased risk of respiratory complications. So Black children with diagnosed with asthma, probably on an inhaler, that may reduce their baseline reactivity. And Black children not diagnosed with asthma have untreated or unmitigated reactive airway potential, and that's why they have higher risk. Now, how else can we test this hypothesis? Well, could we just treat all kids with severe OSA with an inhaler during a procedure? That would be one way. Well, if this reactive airway is causing the problem, give them an inhaler. Or is there a better way to screen for reactive airway disease? If that's the problem, then if we screen for kids, oh, you have severe OSA, but you don't have reactive airway, you're less likely to have a problem. And then can we document the asthma severity? So we know they have asthma, but can we document how well controlled it is? And then can that let us determine the risk of respiratory complications after surgery? And then what does the model suggest about kids who don't have asthma? Why is it that asthma makes it worse, but having asthma in Black kids makes it better? Again, my thought is that the Black children's reactivity is just so much greater that giving them an inhaler overall reduces the rate, where others, the reactivity is not as profound, if you will, or not as sensitive. And so just having asthma increases the risk, but the risk was already fairly low. All right, thanks for listening. Leave any comments below. I'll be happy to answer them. Thanks.